myself Dr. Roshni, your OBGYN faculty at DigiNerve. Now we are all gathered here for the MCQs, and this is for mostly related to the INI-CET, which is close by. Yes, I understand you're all stressed out for the exams, but ease for next 1 hour. Let us discuss most important topics and related MCQs. Okay, I won't give you a difficult questions, very high level questions and make you get scared, or very easy questions and make you feel overconfident. We'll go in a moderate way so that you will be able to answer most of the questions in your exams. Okay, so we have included theory based, remembrance based, clinical based, image based, all the questions we have included in this webinar. Okay, so let us begin it very fast without wasting any time. I know we are already delayed by the first 10 minutes. So to begin with the first question, decidual space is obliterated by 10th week, 12th week, 18th week, and 16th week. Okay, so what is decidual space? If anyone of you has any doubts or any clarification you need, you can write down in the chat box. We'll definitely clear in the last and without interrupting anything in between. Okay, so that will be easy for us to continue for the session. So as we know, what is the decidual space? There are three deciduas. That is, if this is the embryo, the one covering that will be decidua capsularis. Below that will be your decidua basalis, and which is covered to the uterine wall will be your decidua parietalis, isn't it? So this basalis, when this decidua basalis will get fused with that of the chorionic frondosum. Okay, when these two gets fused, it is called as decidual space obliteration. As the embryo grows, the capsularis and parietalis will get fused, will become one. Decidua basalis and the chorionic frondosum, the chorionic villi, when these two get fused, it will form the actual placenta, which will help for the fetal growth. So this fusion, when will it happen is the question. Okay, so what do you understand by this? It happens starts by 6th weeks and is completed by 12th week. So it actually tells when the placenta taken over, when does the placenta actually taken over. That also is a many times asked question, isn't it? Maybe they can ask you like this time. So the correct answer will be 12th week. So I've given you a picture, you can see here. This is the chorionic frontosum and this is the decidua basalis. When these two get fused by that of a 12th week, when these two will get fused, and by then capsularis and your decidua parietalis also will get fused. The one to the uterine wall is the parietalis, one above the embryo is the capsularis, one below embryo is the basalis. Okay, so when these two, basalis and the frondosum will get fused, will form the obliteration, and that will form the placenta that starts by 6th week and is completed by 12th week. Okay, going ahead with the next question. Prolonged expectant management in a case of superimposed preeclampsia is associated with increased risk of maternal conditions like what in the future years. So that is it hypothyroidism, is it maternal cardiac disease, embolism, and diabetes mellitus? Yes, whenever a case of hypertension is superimposed by preeclampsia, why do we do all this termination? If it is a severe preeclampsia, terminate as by 36 weeks to 38 weeks when the fetal maturity is attained, or emergency section can be done anytime after the viability, isn't it? Because if it is in case of a severe preeclampsia, the same thing in superimposed preeclampsia, they also, even if it is well controlled, by 38 weeks we terminate. Why? Because if you delay her, if you prolong the pregnancy by expectant management, the load on the heart will increase. They'll have very high chance of maternal cardiac disease in the future years. So the correct answer here would be maternal cardiac disease. Okay, that is why you should avoid prolongation of pregnancy in a case of superimposed preeclampsia. Only a well-controlled preeclampsia can be prolonged till 39 to 40 weeks. In case of severe preeclampsia, anytime in an emergency you can terminate, or till the fetal maturity you can prolong for another 20 to 48 hours. That's all. Okay, if you prolong, there are many maternal complications. That is why you don't want. So next question. A 32-year-old primary gravida at 34 weeks of gestation with severe preeclampsia, that is, as we told now, severe 160 by 112 mm of Hg, 3 plus proteinuria, severe headache is there. Okay, what do you understand by severe headache? Okay, even with all these things you can wait, but severe headache is a imminent sign. These are the imminent signs. What are the imminent signs for eclampsia? So from preeclampsia she will end up becoming a eclampsia. Remember, preeclampsia can only be treated pre-eclampsia is treatable, whereas eclampsia is a preventable. You can avoid getting seizures. Okay, that is by proper management. Pre-eclampsia you cannot prevent, even by giving your early monitoring. Doppler changes are there, screen positive for PIH, all these things you can only prevent eclampsia, but you cannot prevent pre-eclampsia. Okay, remember this also. Is admitted and she has no prior history of seizures. What is the following intervention crucial for immediate management? Okay, one, first and foremost, in any case where there is a imminent signs, first thing you should give is magnesium sulfate. Yes, so magnesium sulfate, many questions in every exam, definitely there is a question on magnesium sulfate. You can remember even in a recent NEET PG exam also there was a question, isn't it? So just the magnesium sulfate, we have multiple times discussed what are the what is the dosage, what is Zuspan regimen, what is Pritchard regimen. Pritchard is your IM regimen, which you should know. What is the loading dose? That is 14 grams. Okay, all these things are mandatory that you should know. Okay, but remember, you know when to give, what are the signs, what are the signs that you should monitor, like for example knee jerks, respiratory rate and output are the three important things which you monitor during giving magnesium sulfate. So before that, when to give is whenever there is eclampsia, bar whenever in a pre-eclampsia there is imminent signs. What are the imminent signs? Headache, blurring of vision and epigastric pain. These are the prominent imminent signs. Whenever it is there, you should better give the magnesium sulfate. Even in a case of severe preeclampsia like BP is more than 160, 110, even without signs also you can still give. It also helps in protecting the baby against neuroprotection, isn't it? So that is why you can still give. Administer calcium gluconate. When do you give calcium gluconate in this case? Whenever there is magnesium sulfate toxicity, that is when you will give a calcium gluconate, not for preeclampsia. Administer intravenous magnesium sulfate for seizure prophylaxis. So what is intravenous regimen called? Zuspan regimen. Yes. Prepare for immediate induction of labor at 34 weeks. You can still wait giving magnesium sulfate and give a steroid and then terminate the pregnancy. Okay. Restrict fluid for 500 ml per day. It's not required. Next question. A 28-year-old Gravida 2 Para 1 woman with 28 weeks of gestation presents with painless vaginal bleeding. Ultrasound confirms a complete placenta previa. She is stable and fetal heart rate is reassuring. Okay, so this is a case of APH, isn't it? APH is also one of the important topics. So in APH, there are two major categories. One is abruption, one more is your placenta previa. So here they've given very clear sign of painless vaginal bleeding as sign of placenta previa. Again, they themselves have described as complete placenta previa. Okay. So she is stable now and fetal heart rate is reassuring. So in APH, plan for termination depends upon the stability of the patient and also your fetal heart rate condition and also period of gestation. Here she is just 28 weeks period of gestation. That means she has just attained the viability. So we have to still wait for the maturity of the fetus. What is the most appropriate management in this patient? Immediate cesarean section. You can do, patient will get better, but then you will not be able to give any fetal condition. Morbidity of the fetus will become very high, both morbidity and mortality. So we would not want that, isn't it? Expected management with hospitalization, close monitoring of bleeding and contractions. Yes, this is your McAfee-Johnson's prophylaxis where you give a expectant management, complete bed rest for the patient. Okay, with that close monitoring for bleeding and fetal heart rate until at least the fetal lung maturity is attained. Okay, so till then at least you hospitalize her and give under close monitoring. You have to monitor her. If the same thing that given as unstable patient and or fetal heart rate is absent, then you may have to go for immediate termination, not in a case where everything is stable. Vaginal delivery with immediate availability of blood product. Will you allow a complete placenta previa for a vaginal delivery? No, definitely not, isn't it? Because in case of a placenta previa, that to a complete placenta previa, it is a direct indication of cesarean section. Yes. Administer tocolytics to prevent preterm labor. No, here not. We are not worried about preterm labor. We are worried about APH. So your correct answer will be your answer B, expected management. Next question, a 33-year-old gravida 1 patient, that is your primary gravida with 39 weeks of gestation, has uncomplicated pregnancy but is concerned about prolonged labor. Okay, she's already 39, she's thinking I'm still pregnant, when will I deliver? She asks if routine induction of labor at term is recommended to prevent adverse outcomes according to WHO guidelines. Okay, this is about induction of labor. So there should be a proper indications for induction of labor. Unless otherwise, you should never induce labor. Okay, so as per the recent guidelines, induction of labor at 39 or 40 weeks is not recommended. Only after 41 weeks it is recommended. What is the recommendation regarding induction of labor in uncomplicated pregnancies? Okay. Routine induction of labor at term is recommended to reduce cesarean section rates. No, this inductions increase the cesarean section rates. So that is why we are not doing a routine induction. This is wrong. Routine induction of labor is not recommended in uncomplicated pregnancies. Yes, routine induction should not be done. As in this case, she's just a gravida at 39 weeks. In an uncomplicated pregnancy, there is no indication for induction. Induction of labor is recommended only after 41 weeks. Yes, this also is correct, but what you will recommend her is, you will tell induction of labor is not recommended now for you because she's only 39 weeks. Induction of labor should be considered only if there is a suspected fetal macrosomia. It is not only fetal macrosomia. Any case, whenever induction is required, maybe if it is an IUD or if it is 41 weeker, if there is associated Rh negative comorbidities like severe preeclampsia, severe GDM, in such cases only you will induce the patient. Okay, otherwise you would not do a routine induction. This is what you should advise to the patient. Which of the following maternal conditions are identified as risk factor for high risk pregnancies requiring intensive monitoring? Okay, what are the high risk pregnancy? This is what I meant to ask for you. Yes, height less than 145 centimeters. Is it important? Yes, she comes under short stature. Okay, short stature is one of the high risk factors because fetal engagement would not happen at term, or there will maybe chance of over distension of the abdomen, pendulous abdomen. So in such case, short stature has very difficulty in vaginal delivery. Okay, that is why we should always be cautious in this patient. She's a high risk patient, requires monitoring. Weight more than 95 kgs, so she is a more obese patient. So all BMI more than 30 should be closely monitored in pregnancy. Okay, they have very high chance of developing all comorbidities, hypertension, GDM, fetal anomalies, everything. So in the sense, they also require close monitoring. History of previous gestational diabetes, very high chance of recurrence. So this pregnancy also she might recur, so close monitoring. Age more than 35 years. Teen pregnancy or elderly priming, both of them are high risk factors. Extremes of age is high risk factor. Associated comorbidities like renal disorders or cardiac disorders or any other liver or any other disorders, known case of seizures, comorbidities is a high risk factor. Previous cesarean section is one of the commonest high risk factor these days, and anemia prior to pregnancy is a high risk factor. So all these high risk pregnancies require a close monitoring. During vaginal delivery, shoulder dystocia is encountered. Okay, what do you understand by shoulder dystocia? The head is being delivered, shoulders are yet not being delivered. After applying McRoberts maneuver, suprapubic pressure, the shoulder remains impacted. Okay, you have done a suprapubic pressure and you have done McRoberts maneuver. What is the McRoberts? It is abduction and hyperflexion at the hip joint. So when you do that, the sacral angle, the diameter will increase and disimpact the shoulder. Even after doing that in suprapubic pressure, there is no improvement. What is the next available measure? Initiate fundal pressure immediately. If you do fundal pressure, the uterine fundus, you push the baby, what will happen? Shoulder will get even more impacted to the pubic symphysis, under the pubic symphysis, isn't it? So it will not come out. Never do a push or pull in case of shoulder dystocia or a breech delivery. Okay, never you should attempt. So breach I discussed in our recent INI-CET. So I have given this shoulder dystocia. Perform Zavanelli maneuver. What is Zavanelli maneuver? That means you push the baby inside and do cesarean section. It is not so easy to push the baby inside. Uterus has pushed it out. You cannot push it so easily. It's a very difficult maneuver. Doing a cesarean in that case is really very fatal. Okay. Attempt internal rotation maneuvers. Yes, this is what you should do. You should do your Woods corkscrew maneuver or Rubin's maneuver, where you will rotate the baby. Anterior shoulder will be pulled back and posterior will be pulled anteriorly. So when that happens, the shoulder will come down and it will be easy to deliver the fetus. Okay, that is why you should initially do your Rubin's maneuver immediately after your McRobertson suprapubic pressure. Remember, you should give suprapubic pressure in the direction of the back, not against the direction. Okay, so that is when you do, you will reduce the distance. The bisacromial diameter will be done. This is the first and the best method. Only if that fails, you'll go for a rotational maneuvers. Proceed to immediate cesarean section. Note that and analyses are the same. Next question. A 30-year-old woman at 6 weeks of gestation present to the emergency room after high-speed vehicle accident. She is hemodynamically stable but reports abdominal pain and vaginal spotting. Okay, so fetal heart rate monitoring shows uterine contraction. Your NST has a uterine contraction and subtle late decelerations are there. What is the most appropriate clinical scenario in this case? So, placenta. Okay, another case on your APH, abruption. Okay, one commonest cause for abruption is what? Yes, hypertension is the commonest cause for abruption. After that, trauma is the second common cause for abruption. So whenever you can see here, she's having uterine contraction. What type of contraction? It will be a continuous kind of a pain. In your history, if they describe as a continuous pain, then you should think in terms of abruption. Painful bleeding, abruption. Okay, so following an accident. One more is when you do an ARM, sudden gush in polyhydramnios, sudden reduction, sudden decompression of the uterus. Okay, these are the common causes for abruption. So correct answer here is placental abruption. What is the management? Immediate cesarean section. 20-year-old primary gravida experiences a peripartum hemorrhage. So PPH due to vaginal delivery and cervical laceration. Vaginal and cervical laceration she has. Instrumental vaginal delivery, she is hemodynamically unstable. Okay, PPH means only patient is getting into unstable despite fluid resuscitation. What is the immediate management? And we know here it is a case where there is a cervical tear and vaginal tear. Unless you close the bleeding spot, there is no point in giving anything from above. Everything is going down from below, isn't it? So first you should suture where the bleeding is, or cauterize or clamp it. Only you will be able to reduce the bleeding, and whatever you give to her, you give fluid resuscitation or blood, will help her. Okay, so first is do the suturing. Administer to uterotonics. So here there is no uterotonics action. In case of an atonic PPH, uterotonics is of value, but here you should suture it, isn't it? Obtain immediate surgical repair of the laceration. Yes, you should do a surgical repair. Insert Bakri balloon for uterine tamponade. These are all for a atonic PPH where uterus is relaxed. Perform bilateral uterine compression. These all are not going to help us. Since I've done a webinar on a PPH atonicity management, this question I included here. A 34-year-old gravida 3 para 2 women with history of 2 previous cesarean section presents at 30 weeks with sudden sharp abdominal pain and minimal vaginal bleeding, and fetal heart rate monitoring shows prolonged deceleration followed by a absent fetal heart. So this is a classic case of ruptured uterus. Okay, so uterine rupture, correct. This is the answer. On palpation, presenting parts have no longer engaged. What is the most likely clinical diagnosis? So what are the signs of uterine rupture? So I've given you this. You can take a screenshot of this and take a note of this, because this is very important. They will ask you in your exams. So these are the classical signs for uterine rupture. Whenever there is a receding of the fetal head, okay, the initially post cesarean pregnancy they were doing a PV, head was at +2 station, now it is gone to 0 station, and pain was there initially, uterine contraction, now patient doesn't have any pain, she is in shock. That means it is a clear case of uterine rupture. So these are the different histories that they can give you. Next, which of the following accurately describes the purpose of partogram in the normal labor? Partogram is recently called, the new partogram is called WHO Labor Care Guide. Okay, Labor Care Guide. This is the latest partogram. To determine the optimal timing of epidural analgesia? No. Graphical record of the progress? Yes, it is a graphical record of progress. Labor, identification of deviations from normal labor. To predict the exact time of delivery? No, we don't need partogram for that. Lung maturity in labor, so it's absolutely wrong. Next question. Oh, before that, this is your WHO Labor Care Guide, the recent partogram. As you can see here, there are 7 sections in this. Since it is recent, I am expecting a questions on these. So WHO Labor Care Guide, the section 1 is for the initial details of the patient, name of the patient, what parity, what comorbidities, whether she came in rupture of membranes or from when she is in active labor. These are the details initially you have to fill. Section 2 comes for the supportive care. So this is also recent addition. Here you should allow a companion to the patient. Okay, there is a column for a companion to the patient. You should allow for a companion to the patient. Then pain relief, oral fluids and posture. Then comes your baby. So this is the supportive care of the baby. Here you will monitor the fetal heart rate, baseline fetal heart rate. Are there any decelerations? What is the amniotic fluid level, or what is the color of the amniotic fluid level, whether it is meconium stain or a blood stain or a clear liquor? What is the fetal position, whether it is anterior, posterior, transverse, caput and mouldings are there or no? Then comes your women, supportive care for the women, where you will check her pulse, BP and temperature and urine output. Then is your actual labor progression. Here you will check for the number of contractions and duration of contraction. I'm sure in your internship they would have made you check lot of labor contractions, isn't it? What is the frequency, what is the duration and what is the strength? So strength is not mentioned here. They only mention the number of contractions and duration of contraction. And then comes your cervical dilatation. So what dilatation is she in? 5 centimeters, 6, 7, 8, 9, 10. So here only they will give you, if she is 5 centimeters, in next 6 hours she should deliver. If she is 8 centimeters, in next 2 to 2.5 hours she should deliver. So that is what is given in your next column. Then is your descent. Where is the descent? 0, +1, +2, +3. Then comes your medication, whether any oxytocin has been given, or for cervical ripening any medication has been given, or IV fluids what have been given. This section 7 and section 2 are the important additives, where you are adding a companion in the section 2, and in the 7 you will give your assessment. Okay, she is progressing well and will require few more hours for delivery, or will require oxytocin for augmentation of labor. Whatever is your assessment, you will write here and discuss the plan with the attender, and you will sign here. This is your complete partogram. Okay. Next question. Let us rush. We are getting late now. We're already in 12th question at half an hour. A 30-year-old primigravida is in active labor. During continuous fetal monitoring, she exhibits sinusoidal fetal heart rate pattern. Okay, so now that she is having a sinusoidal fetal heart rate pattern, what it means? It is like this. You would have seen in your, not exactly in clinics, maybe in your instruments chart or something in Viva, isn't it? This chart will definitely be there. A sinusoidal wave pattern. What is the clinical significance of this finding? So sinusoidal wave pattern is seen in fetal anemia. So where mostly it happens? In Rh negative patient, where there is fetal anemia. So is it a reassuring pattern? No, definitely not. Typical associated with fetal sleep cycle? No. Here in sleep cycle there may be reduced or fetal variability. Okay, there you can see a reduced fetal variability, that in the beat to beat variability would have wo thoda kam ho gaya hoga. Okay, it is not reassuring pattern, often associated with severe fetal anemia by hypoxia. Yes, this is the correct answer. It requires repositioning of the maternal and administration of oxygen. No, this is also not correct. And next question. A 25-year-old first gravida woman at 7 weeks of gestation presents with vaginal spotting and mild lower abdominal cramps. Ultrasound confirms intrauterine gestational sac with a viable embryo and a cervical os is closed. What is the appropriate diagnosis? So, what are the different types of abortion? You know, now the uterus is there, embryo is there, heart rate is good, os is closed, everything is there, but still she had some amount of vaginal spotting. That is all. So this is a case of a threatened abortion. So she can continue her pregnancy, no problem. That is why this is a threatened abortion. If it had progressed so much that you cannot come back, you can say the vaginal sac was seen in the uterine sac, or the gestational sac was seen in the cervical os, or it was seen in the vagina, then you can say it as inevitable abortion. Or it is a complete abortion when you can see nothing inside. Ectopic pregnancy when it is outside the uterine cavity. And one more will be your incomplete abortion when part of it was out and part of it only retained products are seen on scan. Next question. A 35-year-old woman presents to the emergency department with sudden severe unilateral abdominal pain and vaginal spotting. Her last menstrual period was 6 weeks ago and her urine pregnancy test is positive. Okay, what is the triad for ectopic pregnancy? Ectopic pregnancy triad is amenorrhea, vaginal spotting, and pain abdomen. So our patient has all these things. Amenorrhea 6 weeks ago, vaginal spotting or bleeding PV also she had, and pain abdomen also she had, severe lower abdominal pain. Why is it not a ruptured ovarian cyst? UPT is positive. Firstly, secondly, why is not acute appendicitis? We should always rule out ectopic pregnancy with all these classical features. Hemorrhagic ectopic pregnancy. Yes, it is a ruptured ectopic pregnancy. That is what they mean. Threatened abortion. No, not at all. Why is it not a threatened abortion in ectopic pregnancy? Yes, she has a unilateral pain abdomen. Is it finding which we are seeing? One more thing which is peculiar for PID and ectopic is what? Same finding in PID and ectopic, you have cervical motion tenderness. So whenever they give your PV examination, fullness in one column and cervical motion tenderness was there, it is a case of ectopic pregnancy if UPT is positive. If they give severe vaginal discharge and pain abdomen, then your cervical motion tenderness is positive, it is a PID. Okay. Next question. In context to the early pregnancy loss, what is the role of cervical ripening using medications, misoprostol, before surgical abortion or vacuum aspiration or DNC? So, what do you understand by cervical ripening? Is it to prevent uterine infection? No. So, if this is the uterus, we are inducing contractions. By giving misoprostol, we'll induce contraction. Before that, we want the os to be ripened. That means cervix to be ripened. That means to soften the cervix, the loose area tissue, to soften this so that it will be easy for it to dilate. So to dilate the cervix and reduce the risk of cervical injury. This is what we mean by ripening of the cervix. To induce fetal demise and perform procedure, no. To assess for ectopic pregnancy, no. Okay. So what are medical methods for abortion? That is using your misoprostol, mifepristone, methotrexate are medical methods. Surgical methods are your manual vacuum aspiration, your suction evacuation, vacuum aspiration, dilatation and evacuation are the surgical methods. Next, coming to 16th question. A 27-year-old primigravida at 37 weeks of gestation is admitted in active labor. She expresses a desire of positive childbirth experience according to Lakshya guidelines. This is your latest guidelines, the Lakshya labor room quality assessment section, where which of the following practice should be avoided to ensure respectful maternity care? Okay, this is the recent thing, a respectful maternity, not to abuse the pregnant woman during delivery, not to harm her, injure her, give her a companion to be of her own, to be with her all time and talk to her politely and softly. Okay, providing a privacy during intrapartum period. Yes, this has to be done. Should be avoided is the question. Okay, this has to be done. It cannot be avoided. Allowing freedom to choose the comfortable position for delivery. Yes, she can take her own comfortable position for delivery. You don't have to force her for one single position. This is also correct. Insisting on the conventional lithotomy position for delivery. So your B and C, both of them are contradicting. One of them should be answered. So you cannot give lithotomy position. You have to lie down like this only and deliver. No, if she wants to deliver even in a squatting position, doctor should be able to deliver her. Okay, that is the respectful maternity care. So recently knowing about the water birth, all these things, isn't it? That is what it means. Presence of a birth companion during labor. This also is mandatory. Next question. Which fetal orientation is considered most favorable for vaginal delivery? Breech, no. Transverse line, definitely not a vaginal delivery option. Occipito-anterior, posterior. Occipito-anterior is the commonest one and more chance of vaginal delivery, and in that too, left occipito-anterior. In breech, what is the commonest position? Right sacro-anterior. Okay. Next question. In context to the basics of obstetrics, what is the anatomical landmark used to define zero station of the fetal descent? So when do you say head is at zero station? When head is at the level of ischial spines. So correct answer is ischial spines. So what are the other importance of ischial spines? So here at the level of ischial spine, that means external or cervix is at the level of ischial spines, and your vaginal prolapse is also measured at the level from the level of ischial spines, and also ischial spines is where the internal rotation will happen. Okay, first thing your descent of the head, then is your prolapse, the positioning, then is your internal rotation. It happens at the level of ischial spines. And bispinous diameter, both the ischial spines, the bispinous diameter is the least pelvic diameter. It's approximately 8 to 9, least. Okay, usually it is 10 centimeters, but if it is less than 8 centimeters, you cannot do a vaginal delivery. Okay, that is the least pelvic diameter. And also here around this, the pudendal nerve will go take a turn around this. Okay, and your levator ani muscles originate from here. Okay, these are the importance of ischial spine. A 35-year-old multiparous woman is considering long-acting reversible contraceptions, LARC. She is concerned about the effectiveness and ease of the use. Which of the following is considered LARC methods except oral contraceptives, contraceptive implants, and injectables and intrauterine device? These are all long term, isn't it? The DP is at least 3 months, implants and all are 5 to 10 years, IUCD is also 5 to 10 years, isn't it? So they are all long standing. Only OC pills is on a daily basis. So this cannot be a long acting. This is a short act on a daily basis. So this is wrong. Rest all are LARC. Okay. Next, a 55-year-old postmenopausal woman presents with abnormal vaginal bleeding. Her last menstrual period was 5 years ago. Transvaginal ultrasound shows endometrial strip thickening of 12 mm. Okay, a postmenopausal patient with ET of more than how much? Yes, 4 mm. ET of more than 4 mm is considered abnormal and should undergo evaluation by endometrial sampling. What is the most appropriate next step in our evaluation? Reassuring and repeat ultrasound in 6 months? No, not at all. Immediate history, endometrial biopsy. Yes, anyone whose ET is more or in a perimenopausal age group, clinical symptom of abnormal uterine bleeding, next best method would be your endometrial sampling. Okay, what is the gold standard for endometrial sampling? It is by hysteroscopy. Okay, this also is multiple times asked question. Hysteroscopy guided biopsy. Okay, oral progestin therapy, no. Next question. Which of the following statements regarding gestational trophoblastic disease is accurate? GTD is always benign, resolves spontaneously, complete. No, is it GTD always benign? No, GTD is a classification of both gestational trophoblastic disease, that is your hydatidiform mole, and your in carcinomas, GTN. So GTN are your gestational trophoblastic neoplasm. So neoplasms are what? Invasive mole, choriocarcinoma, placental site trophoblastic tumor, and your epithelioid trophoblastic tumor. So GTD includes both of them, your complete mole and incomplete mole, and your GTN. Okay, both of them come under GTD. It cannot be always benign and resolve spontaneously. Wrong answer. Complete hydatidiform mole typically has normal fetal tissue. No, complete mole has no normal. In fact, a partial mole has some amount of fetal tissue. That is also not normal fetal tissue. Wrong. Persistent GTD requires close monitoring with HCG levels and chemotherapy if indicated. Yes, you have to do her you have to do her beta HCG monitoring. So what is beta HCG monitoring? How will you do? Initially, you will start doing after the evacuation on after 4th day, and then you will do on 7th day. Then you will do every weekly until it completely disappears. Once it disappears, then you have to do it monthly for next 3 months. Then after that, every 3 months, then for 6 months. Okay, that is how you monitor, follow up for a beta HCG. Choriocarcinoma is a low risk for GTD. No, choriocarcinoma is a type of GTN. It is not low risk. This is high risk patient who has developed a CN. Next question. A 28-year-old woman with history of abnormal uterine bleeding is diagnosed with atypical endometrial hyperplasia. So the recent classification, endometrial hyperplasia is only two types, with atypia and without atypia. So our patient, what they are giving is with atypia, with atypical endometrial hyperplasia. She is desired of future fertility. So she is just 28, not completed her family. She wants her uterus to be preserved. So what you will do is potential management option for this patient. So atypia is, but she is not already a CA. Okay, so what you should do to prevent or regress or reverse this atypia is give a long standing progesterones. If ever the same patient was a 55-year-old postmenopausal patient, then your option would be hysterectomy. Since she is young and wants to conceive, you have to give high dose oral progesterone therapy, not do a hysterectomy. Immediate radiation and observation without any treatment is not the correct answer. Okay. Next question. A 30-year-old woman has been trying to conceive for 3 years. HSG shows bilateral corneal block. Okay, HSG is what? Hysterosalpingograph. So here you will push a dye through the cervix, and it will, under X-ray you can see whether the dye is spilling through the fallopian tube or no. In the X-ray you are not to see any spillage. So corneal block is there. What is the most appropriate step? So corneal block means here there is a block because of which the tube or the dye did not enter into the tube at all. Okay, so now there is a block. What you will do? Diagnostic laparoscopy. Yes, this is the best option. Sometimes what happens, even during when you push the dye, because of pain, patient uterus may contract. Okay, because of severe pain, uterus may contract and block. This can get blocked. Okay, it can give a false report of corneal block. That is why under anesthesia you should do a diagnostic laparoscopy and chromopertubation. It is called chromopertubation. When you push the iodine here, and you will see on a laparoscopically whether the dye is getting spilled or no. Okay, that is how you will assess. Next best should always be confirmatory. HSG is only screening. If it is a spillage is there, well and good, no problem, tubes are open. If it is a block, you should confirm by laparoscopy. Even if still there, if they say on laparoscopy the corneal block is there, then you should go for IVF pregnancy. Clomiphene citrate, you cannot induce the patient. Even if the egg is released, egg and sperm would not meet because of the blockage. Tuboplasty you cannot do because tuboplasty is done for if there is any tubal abnormality, not at the level of the cornu. Next question. A 14-year-old girl is bought for vaccination. HPV is recommended for her under National Immunization Program. Which HPV? So the recent Indian made HPV is Servavac. Okay, it is a quadrivalent vaccine for 6, 11, 16 and 18. Your high risk and low risk both are included in this. The quadrivalent vaccine Servavac. Okay, not the Gardasil. This is the one which is Indian made, and it is included in our national, trying to get included in our national immunization program. Okay, when do you give? If the age of the child is less than 14 years, 2 doses, 0 and 6 months. If the child of the age is more than 14 years, then it is 3 doses, 0, 1 or 2 months and 6 months. So this is how you give for a vaccine. Then comes your next question. A 13-year-old girl with presence with short stature, webbed neck and delayed puberty. Her karyotyping is 45XO. Everything is given in the question. That is your Turner syndrome, isn't it? What is the hormonal level of this patient? So in Turner syndrome, what will happen? Your streak ovaries are there. So ovaries are very thin. So what will happen? To make the ovary release the egg, who will stimulate the ovary? Your pituitary. So pituitary will be over functioning. Which hormone does pituitary secrete? It will secrete your FSH and LH, isn't it? So it will secrete more FSH and LH so that your ovary will get stimulated. Whereas what will happen to the estrogen and progesterone is very low because ovary is not functional, because it is not coming from the ovary. High levels of FSH and LH. Yes, this is only the correct answer. Low FSH, normal, no. High estrogen also is not possible because ovary is not releasing at all. Once the estrogen becomes high, then only it gives a negative feedback mechanism to the pituitaries to stop releasing FSH-LH. So since there is no negative feedback, your FSH-LH is continuously getting secreted. So where else do you see very high levels of FSH and LH? In postmenopausal age group patient. If a perimenopausal age group, 6 months I have not got menstruation, then you should check your FSH and LH. Maybe she's attaining menopause. Or in case of premature ovarian failure, okay, if there is a premature ovarian failure also, high levels of FSH and LH are seen. Next question. A primary source of progesterone in the luteal phase. So what is luteal phase? In normal menstrual cycle, you see a normal endometrial growth, that is your secretory phase, and your proliferative phase, and then comes your secretory phase. Here the glands will keep on dilating. So this is your secretory phase. Luteal phase is your second half of the cycle. So in second half of the cycle, who is releasing the progesterone to increase this, make the cells into secretory phase? It is by your corpus luteum, isn't it? The ovulatory phase, ovulatory and endometrial cycle, two cycles you would have learned. Your ovarian cycle will have this corpus luteum, which will be helping to release progesterone. If ever there is a conception, this corpus luteum only will help give progesterone and help the pregnancy to maintain till the placenta comes over, isn't it? So this is the one which will release progesterone and beta HCGs. Next question. Ovarian cyst with homogeneous ground glass internal echoes are seen. What is this characteristic appearance seen in? Ground glass appearance is seen in a case of a endometrioma. Yes, it is seen in case of endometrioma. I've given you pictures also. So this is a case of a endometrioma. You can see a ground glass appearance means it's like this, a clean glass, a clean glacious kind of a material. Okay, so this is seen in endometrioma. So what is this? This is your snowstorm appearance. Where do you see your snowstorm appearance? In your choriocarcinoma, GTDs, isn't it? So snowstorm appearance, invasive mole, complete mole, okay, complete mole. If this gets spread to the lungs, choriocarcinoma, this is your complete molar pregnancy. If this gets spread to your lungs, then it's seen as a cannonball appearance. So what is this? This is very easy. This is a case of PCOS. Correct? No? Polycystic ovaries, pearl of chain appearance. This is called your pearl of chain appearance. Next question. Which of the following is a part of a Rotterdam criteria? Rotterdam criteria is again for PCOS, which was there in last question. So PCOS. High serum cortisol, ovarian volume of more than 10 ml. Yes, this is there. Low FSLH ratio, endometrial hyperplasia. So there are three things in your Rotterdam criteria. What is that? First one is your anovulation or oligomenorrhea or hypomenorrhea. Okay, anovulation or amenorrhea. Then is your serum high hyperandrogenism. Okay, androgen is very high. Hyperandrogenemia or hyperandrogenism, be it in the symptom or in the hormones, wherever there is hyperandrogenism. Then is your scan, that is your ovarian volume of more than 10 ml or multiple cysts less than 1 centimeters of more than 12 polycystic. Okay, more than 12 cysts. All these things are your Rotterdam criteria. Any 2 out of 3 can be there to say it as PCOS. Remember, PCOS is always diagnosis of exclusion. When no other cause is there, then only you can label it as PCOS. Last but one question. Time taken for sperms to reach the fallopian tube is 30 minutes. Okay, once the ejection happens, in another 20 to 30 minutes, sperms will reach your ampullary region for fertilization. Okay, next 20 to 30 minutes, the ampullary region, the sperms will get released. Where the capacitation happens, it starts at the cervix and it will end at the level of the sperm ampullary region. What are the other modalities why the sperm will reach the ampullary region so fast? First, sperm is motile, the motility of the sperm. Then is your uterine contraction. Then is your ciliary movements of the fallopian tube. These are the common things which help for the sperm to reach the fallopian tube for fertilization. What is the lifespan of a sperm? It is 48 to 72 hours. Lifespan of a ovum or an egg, it is for 24 hours. Once the egg is released and waiting for it in the ampullary region of the fallopian tube, it will ejection happens. It will reach there in the next 20 to 30 minutes and the fertilization will happen. Last question. A 33-year-old woman has been advised ovarian reserve testing. What is the marker most reliable? FSH on day 3, yes, you can do, but it is not very reliable. Estradiol on day 2, you can do, but not most reliable. Anti-Mullerian hormone, yes, anti-Mullerian hormone and antral follicle count. Okay, number of follicles. When you start menstruating, the day 3, follicle count, the premature follicles, the number of follicles you have will tell how much ever eggs you have, which will can have chance to get maturity. So anti-Mullerian hormone and antral follicle count are the best methods. Yes, you can do FSH, LH and estradiol also, but remember they are all period day specific, and these two are AMH is not period day specific also. Okay, you can do any time of the month. An antral follicle count, you count over the period of time, but it is usually done on day 2 of cycle only. So this ends your webinar on MCQs for your INI-CET. Most recent topics and your high yield topics have been covered for this INI-CET exams. So all the best students, good luck for your exams, do best. And before concluding, let my coordinator help you with some of the things regarding DigiNerve.